everybody? Are you all sitting comfortably? It's a good buzz. It's lovely to hear it, but we're going to have to press on. We've now got 20 minutes of panel discussion where you are invited to ask questions of our two speakers who've given us the most interesting and stimulating talks. I'm going to take Chairman's prerogative for this little bit and ask Terry how he can be sure in the future that patients will get continuity of care, which is what Julianne mentions in hers, and you did briefly, but which we know patients want.
Thank you. We've been through quite a lot of changes with continuity of care, and as Dennis was, well, it depends what you mean by continuity of care, but I'm going to take it to mean a personal relationship with a GP who is one or maybe two GPs who you see through a long period of time. And what's happened in general practice, there are very few GPs now who work Monday all day, Tuesday all day, Wednesday all day, and Saturdays and Sundays. That's just gone. And what we've got now is an awful lot of GPs who are working the equivalent of 3 days a week, though each of those 3 days is 12 hours each. So in my practice, for instance, where we've all have personal lists, what we have in addition is we have like a buddy system, so that if I wasn't in the practice, then one named other doctor then looks after my patients and vice versa. So in a sense, you have a choice of two doctors, so that if you ring on a Tuesday, I'm not there, it gets sorted out. But if you really want to see me, it gets sorted out by me on the Wednesday type thing. So, but it won't happen if people don't ask for it. And certainly there is a real danger in the major transformation and changes which are currently occurring in general practice, because I'm sure you're all aware of, GPs handing back their contracts, mergers going on all over the place, partners resigning early, partners resigning, becoming salary doctors becoming sessional doctors, because of the difficulties of coping with it all. Unless we ask for it, it won't happen. So the answer is it has to be asked for, it has to go up the agenda as a priority. Government doesn't really see that as a priority at all at the moment, so it has to be asked for.
Julie and then Dennis.
The situation that you described is real, obviously, but I think there's something else that we can also think about. So when I talk about relationship-centred care, I draw very much from the evidence base of Mike Nolan and his colleagues at Sheffield, who have interviewed residents, relatives and staff about what makes life good for them. And it clusters around 6 basic senses that I think we could think about, and it might inform how we work when actually the people we're working with are different, but it might actually help establish a better relationship. So these senses are: everybody needs to feel safe, have a sense of security. Everybody needs to feel that actually they belong, they're part of things, that they have a sense of continuity, that they can connect what's happening now to what's happened before and what is to come. Goals, they need a sense of purpose, achievement, they're moving towards their goals, and actually a sense of significance, that they matter as a person. And I think if we keep this framework in mind when we're with individuals, even if the person's changed, I think this approach can help us better understand what matters to individuals. And when I say what matters, it's important that we know what matters to the older person. It's also important that we know what matters to the relative who visits, and it's also important what matters to the staff. And you can take that learning out of the care homes sector and apply it, I think, across all disciplines.
Thank you. Dennis.
Thank you very much. Well, I must first declare an interest because I'm part of a research team in Exeter that is researching continuity of care, and there's an article that's going to come out in a few months' time, 5,000 words, reviewing the evidence for it. But in summary, the evidence for continuity has never been stronger at a time when continuity of care is steadily diminishing in NHS general practice for the reasons that Dr. Kemple has just given us. But in summary, people who get continuity of care with a general practitioner are significantly more satisfied. They are significantly more likely to follow any medical advice that's given. And the really interesting one, and only recently been found, they are significantly less likely to have an emergency hospital admission. Professor Baker, who our chairman mentioned earlier today, has done a fascinating study which, looking in the Midlands at NHS patients who saw the GP they wanted to see compared with NHS patients in the Midlands who saw any other GP. And the people who saw the doctor they wanted to see were significantly less likely to have an emergency admission to hospital subsequently. There is something about a consultation with a patient who trusts the GP, knows the GP and wants to talk, and the GP reciprocates by actually knowing the patient as a person, which is qualitatively different from any old consultation. Now, absolutely fundamental. I agree, I'm afraid, with Dr. Campbell that this is getting worse, and therefore there is an enormous opportunity for PPGs to stand up and say what you want. You want it because you don't want to keep seeing strange faces and telling your story over and over again. That's correct. But there will be strong scientific evidence available by at least September.
Marvellous. So it's up to us to ask for it
No,
and
she's
to
not from the
ensure
team.
that we
I never
get
won,
it.
and she's a great colleague.
Now, questions from the floor. Over here.
John Price from the Fisher Medical Centre, Yorkshire, Skipton in Yorkshire. With regard to the nursing homes, I applaud what you were saying, but is there not a major conflict that they're owned by people who are profit-oriented, and hopefully the managers are more concerned about the people who are inside? Is that not a big issue?
I think you're right to raise it. I think what we mustn't do is make some general assumptions. There are care homes that are for profit that are actually delivering a really good service to their residents. There are also care homes where the proprietor doesn't really understand the nature of its work, of the work, and they are in it for money, for sure. So there isn't a simple answer here. I think we just mustn't stereotype. But the money actually is largely embedded in the building, and in the Commission on Residential Care, the report chaired by Paul Burstow, the former Minister for Care Services, there was the suggestion that we separate out the housing from care, and I think that's maybe something we should be thinking about.
My name's John Dearden, Helsby and Elton Medical Centre in Cheshire. Professor May, you mentioned the participation of pharmacists in, for example, reviewing medication and so on in care homes. And the government is encouraging the increased participation of pharmacists in this and other ways, but at the same time they are cutting down on the money available to community pharmacy. Where are we going to go?
Every stone you turn over has another set of problems. I really, truly don't know how to answer the question. But it isn't just about reviewing the medication. We want older people in care homes not to have a chemical kosh and to be able to engage in life in other ways rather than being constantly sedated. So we've also got to think about how we do that and how we work with staff to understand what actually is helpful for individuals and how we can manage their care and help them engage in the lives that they want to live. So every stone you turn over, there's more to be found. But yeah, I think the reviews by pharmacists are fantastic and we need more of them, but it's in a problem of resource, isn't it?
Thank you. Robert Pincus, I'm the chair of Enderley Road Patients Association. I ought to say that in Harrow we've linked up all the PPGs, so they come under one banner where we're talking to the CCG, and we now have a compact with them, so they give us some grant to provide some of the services they will do in terms of engagement. Just in relation, Professor, to the comments about the home, you never mentioned anything about volunteers. I am a volunteer. I go into a home once a week. And volunteers often get a great insight, particularly in a charitable setting, but I'm sure in other settings as well. This is the home I go into is a charity. The volunteers get an insight to what's actually going on. You see when you press the button and no one comes along. I just wondered, in terms of all the research you've done, is there any impact on volunteers? Because certainly for charities, volunteers are a significant factor.
The piece of work that we're doing at the moment, funded by the Henry Smith Charity, is all about community engagement, and volunteering is one aspect of that. There's also a project that's being reported at the moment that the National Council of Volunteering Organisations, the NCVO, is leading on. So I think there's information coming out about that. But what matters, I think, is that care homes are in a state of readiness to receive volunteers, that volunteers are prepared to actually understand the context of care homes, and that they're supported to deal with the frailty and the dementia that they find, and that they are helped not to be judgmental but to be curious and to raise concerns that they might have with the staff, and to follow appropriate procedures if they see anything that they are untoward, and to know what those procedures are. So again, with volunteering, it isn't just about people going in. There's so much more. And yet, if we did it, how wonderful that would be. Because I think as a society, we are frightened of frailty, we are frightened of end of life, and we're frightened of dementia. And if actually there were more volunteers in care homes, I think it would prepare us all for what we're all inevitably going to face at some stage in our lives. So I'm really for volunteering in care homes, but being done properly.
Does the CQC reflect the work of volunteers when they go into a home to inspect?
If you look at the outstanding care homes, one of the things that they are particularly pulling out is community engagement, so yes.
And can I add to that, that if PPGs get involved, there will be lots of volunteering in the care homes, and this is what we're hoping for, and this is why Julianne is here today. Somebody at the back.
Hello, my name is Fiona Barber, a PPG member from Greengate Medical Centre in Birstall, Leicestershire. Also, I'm a volunteer patient public voice advisor on NHS England's primary care oversight group. My question to the panel is, how do you think that GPs and their PPGs can best contribute to the development of the prevention and self-care agenda that seems so important now to try and slow the rate of demand, which is continually increasing? Thank you.
Thank you. Terry?
Well, if it was an easy problem, we would have solved it already. So it isn't easy. And certainly, as a GP, when you see patients coming in with problems which really they shouldn't be being seen with, it really sort of is very frustrating, and it's just very difficult, because it's sort of a sense of, I don't know, but I mean there's a sort of sense of somehow something is missing in the community, so they come to the doctor instead. So maybe this is it's giving, we're all desperately trying to find alternative routes. We've already mentioned the fact that, the government says, well, go to the pharmacy, but actually we're going to shut the pharmacies down anyway. So it's somewhere trying to divert people so they get sensible advice elsewhere. Because things like 111 haven't worked very well. They just end up sort of referring lots of patients later on in the day to either GPs or to out-of-hours services. So that's work in progress. I haven't got a simple answer for that. I mean, people say things like, well, we need to start working in the schools. But obviously that's not going to have a tremendous effect that fast. But a difficult problem which we need to address, no simple answer.
Thank you very much. I would like to add to that that we need to remember that most of us do self-care, and the times that we see a professional is very small compared with the times that we look after ourselves. NAP is a member of the Self-Care Forum and works very hard with them to promote self-care, but there is a limit to how much self-care somebody can do on their own without the support of the general practitioner or some healthcare professional. And I don't know whether, Dennis, you would like to add to that.
Well, I very much agree. It's an absolutely huge agenda. There's lots of research that patients can do more for themselves, and there's very good research that when they do, the outcomes of the various chronic diseases are hugely better. The problem, as your question sharply puts, is how to help general practitioners do that. And I have no doubt myself that good general practice is about helping patients to take more responsibility, and good GPs do that very well. It actually touches hugely with the previous question on continuity of care. There's research showing that quite a block of GPs see their responsibility as to the single consultation stop. Many of them are working part-time sessional sessions, and they go home and they see the job as dealing with the patient in front of them. There's a bigger group of GPs who see their role as being responsible for the patient forward over time. And the critical issue for your question is that it's only those GPs who are looking forward to how is this patient going to be next year, could he or she do more, do they need to come. If you are on a single short-term basis, it's not worth your while as a doctor to start educating the patient, because you may never see them again, and they may even take umbrage if they don't know you. So the trick is to build human relationships where the patient trusts the doctor trusts the patient, and the doctor takes a long-term strategic view of what this patient can do more in the future.
Thank you.
I'm Maggie Matthews. I'm a trustee of NAP, but as well as this, I do loads of volunteering on behalf of Staffordshire Health Watch and my local North Staff CCG. As part of the work I do for Health Watch, I carry out enter and view reviews, not inspections, of care homes. And the quality of the staffing varies so massively. I was wondering how we can get some sort of legislation into demanding, if you like, that care homes have to put their staff through training. It seems to be very hit and miss. Some staff have to do the training in their own time. Other staff are, one care home that I go into on a regular basis has a really good, solid programme where they can see where all the training that needs to be done is reviewed perhaps monthly, and then they can take on board when that person needs to do the next bit of their training, and they build it into their working week. That is the extreme, the good practice, and the other is where people have to do everything in their own time, and they need guidance and support, usually because it's an MVQ related, and they need to know how to collect evidence. I was wondering if, as part of this, we could look at activities coordinators in care homes, because that enriches the life of a resident so greatly. We've had a very simple experience of this in the last few weeks, where a friend of ours who's had dementia for about 9 years, been in a care home since last November, never did anything artistic, never knitted or sewed, did anything at all. And her husband came to see us this week, and he bought us a photograph of Shirley in an art class. She hasn't got an artistic bone in her body. Nevertheless, she was really absorbed in what she was doing with a little frame, and it was very abstract, but that didn't matter. She was participating and getting some enrichment out of it. So I'm just wondering about training, really.
Again, another stone to turn over. However, let's focus on what is happening. So in the past, the Care Quality Commission have wanted their social care assistants to be educated to MVQ level 2. And so I think in one of the slides, something like 60% are at that level. But that's a pretty low level, actually, and it's not really taking too much account of the healthcare care needs. We need to do more than that. I think you're absolutely right about activity coordinators. Meaningful activity in care homes is absolutely paramount. But the new thing, we've got a crisis of nurses leaving the care home sector to go and work in the NHS because their pay and conditions are better. And care homes are not waiting for policymakers to solve this. They're having to get on. And we're doing a piece of work with somebody at Duke University who came over from Fulbright as a Fulbright scholar, and she's been looking at some of the innovative stuff that's going on in care homes to address the lack of nurses because they're leaving. There is also a proposal that we introduce something called a nurse associate who will lie between a registered nurse and a care assistant level. Some people feel it's like going back to the days of the enrolled nurse. There are things happening in terms of education and training, but we need more of it and we need it speeded up.
Thank you. Question at the back here.
Paul Lee, Cornish Way Practice, Manchester. What is the average time that a person survives within a care home?
People talk between 6 months to 18 months, a year. That's the rough time now.
I'm talking about the person who goes in for the care.
Oh, it's the worker?
No. I don't call, somebody going into care home a resident.
Yep.
When somebody goes in as a resident, the average period of survival.
Yes. It's 6 months to 18 months, literally.
Right. Okay, thank you.
Hi, I'm Ingrid Brindle, and I'm from Horton Thornley Medical Centres in Hyde. And we've been lucky enough at our practice to have fantastically forward-thinking GPs, and we have had access to our full GP records. That's everything. I've had access to mine since 2006, and there are numbers of instances where this has totally changed the management of my care and that of other patients. And we were saying before, I think it was Terry was saying that the more information patients have, the more engaged they are, the more involved they are in decisions about their care, the better are going to be their health outcomes. And I'm just nervous at the moment that although contractually GPs now have to offer access to coded information, there are a lot of different ways that practices are doing that. I know a practice of one of my colleagues is just allowing access to coded information from the day that the person signs on for records access, so no history of any kind whatsoever. And I think looking at patients being involved in self-care and people managing their health better, I wondered if you had any observations about how we can continue, I think, to change attitudes of some practices, that this is an enormously good thing and it will reduce the demand on your practice and increase, patient safety, basically.
Thank you.
Thanks.
Jerry.
So it's finding the right way to give the sort of feedback to the practice which isn't too threatening. Because if they feel threatened, then their immediate response is to sort of say no to things. But if we're in a collaborative arrangement saying, I'm really interested in my care and I want to do this, then, in my experience, most practices will cooperate. And when they feel safe doing it, they'll be happy to do it. But if they feel threatened, then the barriers tend to go up.
Thank you. Dennis, would you like to add to that?
Well, I think everybody here will agree that access for patients to the record is a very good thing, and on the whole, where it's been made available, people have been very satisfied. There are just one or two technical issues putting the other side of the argument, which is that if patients have given confidential information to the doctor about another member of the family, there are some very tricky issues about how far that should be opened up to the person was talking about. I just raised that as a highly tricky issue. There's another very tricky issue that in some ethnic groups, very male-dominated ethnic groups, the fathers will demand access to the teenage girl's record. And that may include contraception, which is contrary to the ethos of the family. So there are some quite tricky issues. I'm not trying to make a meal of them. I think the legal issue is killed. I mean, it's all over. Patients do have access, and every one of us has that right. It's interesting, actually, how few people take that up. And I think that's an issue for patients to discuss and for people like you who have had benefit from it, but the majority of patients don't exercise their current right.
Thank you. We could discuss that as a main topic. One more question, which was at this gentleman in the middle, and that's our final question.
Francis Brown at Priory Avenue Surgery. My question is to do with footprints and STPs, and those footprint areas which have 7 or 8 CCGs involved in them. Do you feel that where there's a great many relationships between these CCGs, this reduces the chances of their success? To give an example, if you have 3 CCGs, you've got 6 relationships. But if you have 7, you have 46 relationships. And I just wonder if you see that as a relevant risk for the larger, so the footprints that have many CCGs involved in them.
So there are 44 STPs which have been sort of set up, and really these are reinvented area health authorities, but not sitting on the old footprints. And the college is particularly worried because with the GP Forward View, there's a great deal of urgency about getting the resources which are promised in this new extra funding to practices as soon as possible, because they need it now. And one of the problems there is that in many parts of England, NHS England locally barely functions. And certainly there's also a worry that these STPs are going to be secondary care dominated, so that money will be siphoned off towards secondary care and never get towards primary care. So for that reason, the RCGP has taken an attitude that along with the local medical committees, we need to be holding their feet to the fire to make sure that they do their jobs properly, to get the money, rather than anybody that's got anything to do with the NHS will realise money tends to get stuck up the line somewhere and doesn't get to be where it's needed. And what GPs are saying, we don't want to fill in a 20-page application form, wait for 3 months and then be told, oh no, you haven't got the money type thing, which is what often happens. So we're very anxious about STPs in the college. We're very anxious that they will be secondary care dominated, and we're very anxious that the money won't get to primary care as needed. So all we're doing is we're setting up these ambassadors who will, along with our LMC colleagues, trying to make sure that they work, even though they don't fit historical footprints in many parts of the country.
Well, thank you to our 2 keynote speakers and to Sir Dennis for answering questions. It would have been lovely to have had time to carry on, because there are issues in the room and amongst the panel that we would like to have discussed longer, but we have other important things to discuss. So I'd also like to thank you all for asking such interesting questions. So can I give you all a warm vote of thanks, and to our speakers.